Hi, I'm Mohamad Mohty from the Sorbonne University in Saint-Antoine Hospital in Paris, in France. And it is my great pleasure to be with this lovely crew of HealthTree University here in Orlando at the ASH 2025 annual meeting. It's a fantastic meeting, especially for multiple myeloma, lots of excitement, lots of new data. When it comes to newly diagnosed multiple myeloma, I think the treatment algorithm is becoming more and more well-established, very robust. The so-called transplant-eligible patient, I think quadruplet induction, whether with daratumumab, bortezomib, lenalidomide, dexamethasone, dara VRD, or isatuximab VRD are now really considered the standard of care. And the aim of this quadruplet induction is to achieve a very deep response prior to high-dose melphalan and auto transplant, especially if you are able to achieve MRD negativity. And this has been shown actually in the Perseus trial, in the German HD7 trial. With such quadruplet, even before transplant, you can achieve up to 60% of MRD negativity, which is something unprecedented historically. We never achieved such level of response. Then high-dose chemotherapy, melphalan. Maintenance is under debate. Should we use lenalidomide maintenance alone, or should we use doublet, an anti-CD38 monoclonal antibody plus lenalidomide? Well, again, we are in a sort of a gray zone because daratumumab lenalidomide has been approved in Europe for maintenance. It hasn't been approved in the United States by FDA. So I think at the end of the day, it will depend on the disease response, the patient features, to figure out whether everybody will need the doublet or not. Although I personally would think that giving a doublet, especially if we try to aim for a limited duration of treatment, can bring some added value. But I think the future is going also into some exciting directions, developments, by incorporating the immune therapies in earlier lines, especially bringing bispecific and T-cell engagers as part of the induction, but also giving these T-cell engagers bispecific for maintenance, especially again for a limited duration of time. So I think beside the response rate, the very nice progression-free survival data, the next step in the management of these patients is going to be able, in my opinion, and this is of great importance for patients, for the quality of life, to give a limited duration of a treatment. For the non-transplant eligible patient, also the results are very good. The backbone is about an anti-CD38 monoclonal antibody like daratumumab plus lenalidomide dexamethasone. But then we're discussing now the quadruplet, dara VRD or isatuximab VRD, as it has been shown in the IMROS trial or the Cepheus trial. And those patients who are not transplant eligible, they are relatively old but fit enough, can receive this kind of quadruplets, which are very well tolerated. But from a patient perspective, there are also some great advances. We know that moving from IV to subcut is definitely something of importance. And now we're moving to these so-called OBIs, the on-body injectors, which are devices allowing even more autonomy for the patient and a sort of an self-administration of a given drug. And this is being now done, for instance, with isatuximab, and it's proving to be very interesting in terms of quality of life. So you can see the treatment algorithm is well-defined, well-established, but we keep on improving and adding new tools. And this will lead for sure, and we can sense this through the current data, to cure in a significant proportion of patients. And that's exactly the goal. Cure is definitely the key word.